The point is, why do we care about lung cancer? Well, we care about it because it's common. We care about it because it's lethal. So it's actually responsible for the most cancer deaths in our province, and in 2017 accounted for 600 deaths. So why is that? So what makes lung cancer so deadly? So if we look at the pie chart on the right, what you'll notice is that unfortunately, most of these patients are diagnosed at a late stage of disease. In fact, 50% are diagnosed with stage 4 lung cancer, where survival is short and there is not chance for cure. 20% are diagnosed with stage 3 disease, and though it can be treated with curative intent, some patients are not well enough to receive that aggressive treatment, and survival is still under 50%, even with modern treatment advances. What you'll notice is that it's a small portion of patients diagnosed with earlier stages of disease with higher chances of cure. So about 21% have stage 1 disease at diagnosis, and 8.4% have stage 2 disease at diagnosis. And that spread is actually quite different when you compare to breast cancer. So for example, in breast cancer, only 5% have stage 4 disease at presentation. So there's a difference right off the bat in how early we're finding these patients. So that then lends itself to the 5-year survival of each of these cancers. So if one is diagnosed with lung cancer, there's a 19% chance when we look at all comers that they will be alive in 5 years. And contrast that with 93% for prostate cancer patients, 88% for breast cancer patients, and 65% for patients with colorectal cancer. On top of that, survival for untreated stage 4 lung cancer is short. And from Canadian data, that number is actually 3.9 months. And I want you to take that number and remember it, because it's going to be really relevant as we talk through the numbers from our research today. So what this highlights is that the opportunity to act is very narrow for these patients. So we don't have months and months and months to get these patients diagnosed and onto treatment. Timely diagnosis is key to enable treatment. But that's actually quite challenging in lung cancer. So most of the time when patients have symptoms, it's more likely that they will be diagnosed with a more advanced stage. They often require several different investigations to get at what the diagnosis is. And there often is a result for multiple different types of specialists to determine the best treatment plan. So some additional background, what's the data that earlier diagnosis and treatment makes a difference for these patients? Well, we actually do have some pretty good Canadian data, and this is from a publication in Current Oncology, to say that it really does matter for patients who present with curative stages of disease. So patients with early stage lung cancer, which refers to stage 1 and 2 lung cancer, for those with a diagnosis to treatment interval of less than 30 days, their median survival was not reached, compared to a median survival of around 3 years if that interval was more than 30 days. When we look at those with local regional lung cancer, which generally means stage 3 lung cancer patients, it's almost a doubling of median survival if diagnosis to treatment happened in less than 30 days, 33 months, versus 17 months if the diagnosis to treatment interval was more than 30 days. You'll notice that we saw a paradoxical effect in advanced patients, and there may be some reasons as to why. So patients who were diagnosed and treated faster in the metastatic setting had shorter survival. Well, from what I see day to day, patients who get admitted to hospital are very sick and sometimes need palliative radiation to correct their symptoms quickly, but they may not be destined to survive with their cancer all that long because they're already so sick at presentation. Conversely, patients who have lung cancers that are moving slowly enough that they can survive 30 days and get onto treatment may just have more indolent forms of lung cancer. But without question, timeliness is very important for patients who present with curative stages of disease. So we formed a lung cancer working group at the St. John Regional Hospital to address the inefficiencies that we were noticing in the care of our lung cancer patients. So the core group is a joint initiative involving thoracic surgery, radiation oncology, medical oncology, and respirology. And we have been meeting on a regular basis since November of 2017. At various time points, we've also drawn in our colleagues from radiology and primary care, and it was inspired by the OTTAWA lung cancer model. So the OTTAWA model designed lung cancer care as a system design problem. So it's not that individual physicians, aren't doing things properly. It's just that the system doesn't really work well to meet the needs of these patients. So they actually obtained input from patients, families, clinicians, and non-clinicians, and redesigned their whole regional process. So what is it that they did? So first of all, they centralized referrals. So most systems, it's an individual referral to an individual doctor. But here, all lung cancer referrals for new cases go to one place. Those referrals are then reviewed the following day by a chest radiologist, a thoracic surgeon, a nurse navigator. Orders are initiated and a diagnostic plan is dictated. So these patients are actually then going through a navigation day where they meet with a nurse navigator to provide education about the suspicion of lung cancer and the reason for the tests. They get a smoking cessation consult. They meet with social work, and their PETs, pulmonary function tests, and MRI brains that are needed to stage these patients and determine their treatment plans are ordered, and they have dedicated diagnostic slots for these tests. Once these are completed, the patients go back into triage and are then triaged to the appropriate consultants. So this is important because in lung cancer, the PET is really, really important to tell what stage of disease the patient has. So a CT is often not sensitive enough to know what stage they have. And you really need to know that to know whether the patient is best served by seeing a thoracic surgeon, radiation oncologist, medical oncologist, or some combination for their treatment. What did they accomplish? So the main accomplishment is by implementing their model, they cut the time from referral to treatment from a pre-implementation median of 92 days to 47 days post-implementation. So they cut it in half. They were also able to see reductions in about a third for the wait times for PETs and biopsies. And for those of us who treat lung cancer, we would view those two things as really important rate-limiting steps to be able to get these patients on treatment. So there's a common saying amongst medical oncologists, tumor is the rumor, tissue is the issue. So patients don't actually have a cancer diagnosis until we have a biopsy in hand that tells us that they do. So we decided that that should be our goal. We should try to get our patients diagnosed faster and onto treatment faster. This is not just a New Brunswick problem. This is not a Canadian problem. This is a worldwide problem. And there are a number of models that exist at various Canadian centers as well as European centers that are interested in this problem. And most of them have defined their goals as these patients should be on treatment within 8 weeks of the referral being made to a lung cancer specialist. So this was not intended to be a quality improvement research project at its outset, but it sort of bled into that. We realized that we would really need to understand what our current challenges looked like locally to figure out whether it made sense to look at the OTTAWA model, for example, and whether we thought that might improve the wait times for our patients. So we chose the year 2018 to find a cohort of patients who had a pathologically confirmed diagnosis of lung cancer who were cared for at the St. John Regional Hospital. So most of these patients do filter down to radiation and medical oncologists. So the majority of patients were found based on that list. A small portion of patients only ever see surgeons, and we were able to identify them by looking at the operating room list for thoracic surgeons. And that led to a cohort of 246 patients. So what were we interested in? So we really just thought through, what is the trajectory of these patients? So most patients have some sort of symptom, shortness of breath, cough. They have an X-ray. And usually that X-ray then prompts a CAT scan. So there's a delay between those two things. The CAT scan is really when we're more sure that the patient might actually have a diagnosis of lung cancer. And it's usually after that CAT scan, the report gets read, it's sent back to the primary care provider that ordered the test. They communicate that result to the patient, and then they then initiate a specialist referral. Ideally, we would have been able to capture referral in our project, but we would have had to have looked at paper charts in surgeons' offices, and one of those surgeons has since left St. John, so it wasn't going to be possible to collect that endpoint in its entirety. After the patient sees a specialist, further diagnostic tests, including PETs, including biopsies, are ordered, and they're usually ordered at the time of that initial visit. Once those biopsies and PETs are done, the patient is then brought back to the specialist that ordered them to talk about the result, and then may be treated by that specialist or may be referred to additional specialists to discuss treatment and to get on to treatment. So we were interested in what all those various intervals looked like along the diagnostic pathway. So in terms of the first interval, what's the median time it's taking these patients from their abnormal X-ray to get their CAT scan? In our case, that was 15 days. When I put in a CAT scan order as urgent at our center, that does mean 2 weeks. So it would seem that when it's ordered that way, it is happening in that specified time frame. What we notice in clinic is that patients who are seen in the emergency department often have a faster time to getting their CT done. Sometimes it can be arranged that day, or sometimes it's arranged within a couple of days. It's easier for that communication to happen about the X-ray and the need for the CT when the patient is right there in front of you. Whereas the logistics of that are a bit different when these things happen in the office of a primary care provider. Some of these patients may have a legitimate delay. So sometimes people who end up having lung cancer may have what looks like pneumonia on their X-ray. A follow-up X-ray in 6 weeks is recommended. The problem doesn't resolve, and then that prompts a CAT scan. So some of these patients that are out in the 70th or 80th percentile, they may actually be legitimate delays, but we haven't had the opportunity to go back through our data to sort out which ones were intentional and which ones were not. So the next interval is how long does it take from the CAT scan that looks like lung cancer to a PET scan that looks like lung cancer? And the median is 28 days. And again, that's about what I would have guessed. So there is a time lag from when that CT is reported back in the hands of the primary care provider. The primary care provider then needs to tell the patient that it looks like lung cancer and initiate a specialist referral. Most of us try and see those new referrals within 1 to 2 weeks. And then once that PET is ordered, an urgent typically happens within 2 weeks. So a median of 28 days is about what we would have expected it to be with what we see day to day looking after patients. No surprise, the interval from CAT scan to biopsy was the same, 28 days, but they are typically ordered and arranged at the same appointment, and they are typically ordered as urgent, which means within 2 weeks of ordering. Now, what about the X-ray to treatment interval? So when patients have that X-ray, that's really the first objective finding that this person may have lung cancer. And it's taking about 2 months and 3 weeks from that time point to get patients on to treatment. This is not the first time I've talked about this pathway. And one of the questions I often ask the audience is, what do you think about that? So if that was you and that was your X-ray, would that meet your expectations?
No.
And that is generally the consensus that I get. So what about the CT to treatment interval? So that's a little bit shorter. We're looking at about 2 months and 2 weeks. But again, the answer is uniformly no. That's just not fast enough, and especially not with a type of cancer that moves as quickly as lung cancer. This is one that surprised us. So I think our perception as lung cancer treaters was that, well, once we get their biopsy, I feel like we're pretty quick getting them onto treatment, but the data actually says differently. So the data actually points to a median of 38 days from the time of biopsy to when these patients start treatment. And I think our perception was that the delay may be more on the diagnostic side. But once we actually collected the data, that doesn't actually seem to be true. And then we were also interested in comparing health zones. So in terms of where these patients are cared for, we have to remember that thoracic surgery resources and radiation oncology resources exist in St. John, but not in Fredericton. So zone 3 patients are coming down and receiving a significant majority of their lung cancer services in St. John. The only thing that was actually different was the X-ray to CT interval. The median was 19 days for patients who had it performed in St. John versus 43 days in Fredericton. The rest of the intervals are actually remarkably similar between those patient groups. But I do think that once a referral is received by a specialist in St. John, we are often ordering the investigations to take place in St. John, probably because we're quite familiar with what the expected rate is for those procedures. And so what was our spread of treatment? What did that look like? So 12% of patients didn't have any treatment at all. 26.6% had surgery. 16.6% started with systemic therapy. 29.5% had radiation as their first treatment, and 15.4% had chemoradiation, which is a type of curative treatment we offer to patients with a stage 3 lung cancer. But this is probably the most interesting slide from the whole project. And I'll bring your focus to the last 3 rows. So what this is looking at is the X-ray to treatment and CT to treatment intervals based on the types of treatment the patient had. And there's some good news and there's some bad news. And I think the good news is that the sickest patients seem to be moving through the system the fastest. So patients who have stage 4 disease are often offered systemic therapy as their first treatment. Patients are never treated with curative intent with systemic therapy alone as their first treatment, with rare exception. So these are patients with advanced disease. Chemoradiation is offered to stage 3 patients. So their means were 67 and 68 days respectively. The problem is when you come over and you look at the surgical patients, these are the patients that have the highest opportunity to achieve long-term cure. And we're taking the longest to get them through the system. The mean was 131 days. That's more than 4 months. And the other thing that's interesting too is the biopsy to treatment interval was substantially longer for the surgical patients, 66 days. So even once they have their biopsy, they're waiting more than 2 months to get in and have their surgery. Whereas for chemoradiation and systemic therapy, it's happening within about a month. So what have we done so far? What do we need to do? So the one intervention that was within our control as a group of physicians to implement was a centralized referral process for new lung cancer consults. And we did that starting September 3rd, 2019 at the St. John Regional. So what we do is we have a daily physician duty roster to review new referrals and decide the best first specialist contact. What this has allowed for is I no longer get referrals that really shouldn't be meant for me for patients with potentially curative lung cancer. Those go off to the surgeons. Vice versa, the surgeons are no longer getting patients who have advanced disease when those patients really just need to see me. So we've been able to organize ourselves a bit better in that respect. Our initial intent was to collect post-implementation data from the year 2020 to see if we've been able to capture any meaningful differences. But unfortunately, COVID-19 had different ideas and it's limited our ability to collect impactful, meaningful post-implementation data. We have a proposal put forward to obtain funding for a nurse navigator because without this, we really can't implement any of the other next steps. There really needs to be someone that can contact patients, explain the need for tests so they can just be pre-ordered and done quickly. This project has led to further quality improvement research. So we now have a project underway looking at the chest X-ray to CT process. So it seems like low-lying fruit to narrow that interval. As a group, we've come up with some different ideas about how to do that. but then we've decided that we really should research exactly what's happening there to figure out the best way forward. And we also pivoted our 2020 research project to a project looking at the impact of the COVID-19 pandemic on these diagnostic interval weights for our lung cancer patients. So at the very least, we've established what our foundation is, and that's going to allow us to objectively assess the impact on our patients of any further quality improvement initiatives. So it's going to be very helpful for us in that regard. I think we're all hopeful that lung cancer screening will be a reality in this province in the near future, and it will also serve as a baseline to study any impacts of that.